Everyone, and welcome tonight. I'm really excited that we are moving forward with our survivorship series. We have a wonderful panel tonight. Just to remind you, this is Maria Theodoulou. I'm one of the breast medicine oncologists up at New York Oncology, Hematology, and the program director. We are going to have a very quick moving hour tonight. We have a wonderful panel. I'd like to introduce them, and I'm going to start with Heather Stahura. Wave your hand. Dr. Stahura is a cardiologist up in the Capital District. She trained downstate. She did her cardiology training up in Albany, but there is one thing that makes her stand out. Years before it was popular, she took an interest in the side effects that we trying to treat and save and cure our patients with the medications that we have at our disposal today. She took a great interest in a new subspecialty that I think she really started from the ground up in this part of the world, called cardio-oncology. And it's really fascinating. We're going to talk about the kinds of things that women should know in order to keep them well, keep them healthy, and what we should be looking out for when it comes to our patients and side effects. It's been a long day today with patients. Okay, Erica, wave hello. This is Dr. Erica Bove, and she is a reproductive endocrinologist who is also an OBGYN. She's double boarded. She really has not an easy job. You know, women who are young, who are still of childbearing potential, they want to have their families. Maybe they're not married yet. Maybe they've never had a child. And now they're beginning to confront a breast cancer diagnosis and the potential and the possibility of infertility, striving for curative intent. And if I don't drop the laptop again, I am over the top pleased that we have Dr. Azeez Farooki, who I haven't seen you in over 6 years, who is just an incredible endocrinologist. He is an attending physician at Memorial Sloan-Kettering Cancer Center, and he holds a teaching position at Cornell. His interest is bone metabolism. He's one of the thought leaders in the country on bone metabolism and some of the side effects from our bone modulating agents. He also really is interested in some of the issues that most endocrinologists get involved with, and that is diabetes, glucose metabolism, and cancer. He is well authored. He's been published in every major peer-reviewed journal. He's been on the NCCN board, just an incredible speaker and just an all-around good guy. So thank you, Azeez, for giving us some of your time tonight.
Pleasure.
Arsyl,
thanks for having me.
Oh, my pleasure. Arsyl and Colleen. Arsyl is our radiation oncologist who is just so integrated in the community, loves patients, has a tough job, and she helps co-moderate this program that we give about 7 to 8 times a year. And Colleen, my nurse practitioner, who every single one of my patients would absolutely fire me if you would have opened up your own practice. She is not only really dedicated to women's health, but is quite a force when it comes to passion and caring and going that extra 10,000 miles for a patient. So I love you dearly. So we're going to start this off. And although last month we had a very interactive panel because everybody was interested in our health below the waist when we're diagnosed with breast cancer, we have 3 distinct topics tonight. And what I'd like to do, and out of respect to Erica, who has a baby that may start crying at any point in time, Erica, I'm going to throw this at you right now. And certainly the rest of the panel is welcome to join in. Tell me about the average patient that we send to you as medical oncologists. Who's that patient that you see? What is she all about?
Yes, so I am so grateful for your referrals, Dr. Theodoulou, because these patients, what we're learning more and more is that they want to have the conversation. And some people proceed with therapy, some people don't, but fertility and future childbearing is an important topic to talk about, especially in the context of a breast cancer diagnosis. So usually our patients are somewhere between 25 and 42. Some of them are partnered, some of them are not partnered, but usually all of them have some interest in thinking about future childbearing after breast cancer, which is the nice thing, is that we're really talking about life after breast cancer. And I think the good news is that not only have the breast cancer treatments significantly improved, but our fertility treatments have also improved with all the ongoing research. And so we can really marry the two and help give people an opportunity for future childbearing, once they are in remission, which is a wonderful, wonderful thing.
I go back so many decades before we even had fertility as an option in our young patients. And I know when we first started, we weren't really sure about the safety. We all held our breath. Do we really want to stimulate estrogens in a patient who's just been diagnosed with breast cancer? Our understanding was so limited. And as the science evolved, we knew that we could approach our patients in multiple different ways. It wasn't just a matter of getting them pregnant. It was, how do we egg harvest? How do we prepare for after chemotherapy? What are the options if a woman cannot carry on her own? What kinds of medications are we using now that have actually looked at a safety issue with our aromatase inhibitors? So could you speak to, I know I'm hitting you with a lot, but could you speak to that?
Absolutely. So, we now have long-term safety data that the different options we have for fertility preservation, one is egg and embryo freezing. So that's one category. And the other is basically suppressing the ovaries to kind of protect them from the harmful effects of chemotherapy. That both of those, are safe in the context of breast cancer. So they do not increase the risk of recurrence. They don't increase the risk of disease progression. And when we do an in vitro fertilization cycle where we harvest eggs with or without fertilizing those eggs for future use, we can use a medication called letrozole, which keeps the estrogen levels nice and low, so that, that's one of the big concerns, especially with these hormone receptor positive cancers, is that we might be fueling the fire, so to speak. But we know that these treatments are safe and effective. We can get this done in about 2 weeks. And then there's usually actually a nice window of time where we can work with, even get in 1 or 2 cycles. And then, a patient can move on with their therapy. Same thing with the ovarian protection agents too. As a woman's undergoing chemotherapy, we can sort of shield the ovaries from some of the harmful effects of chemotherapy. And we have good long-term safety data that it's very safe to do so. And so I think that I'm very passionate about helping people and also being evidence-based at the same time. It's really nice to have a leg to stand on in terms of the safety of these agents.
The patient questions that I get are, I don't have a partner. What do I do?
Yeah.
There's no one in the horizon, and you're planning to treat me for the next 5 years, and I'm 35 now, and I'll be 40 when my treatment is done. Am I going to be able to do anything? Will I still be able to have a child if I do meet someone?
And that's such a great question. I get that all the time. I think that, the good news is that even in the last 10 years, egg freezing was deemed no longer experimental. And that's because our technology has evolved so much that, eggs are very large cells. They have a lot of water in them. And you think about the ice cube tray in your freezer, when you freeze something, it expands. And so thankfully, we've now gotten really, really good at freezing eggs as eggs without needing to fertilize them. And so it doesn't matter if somebody has a partner. Frozen eggs as eggs do just as well as eggs that go through the process that are fertilized. It's just that embryos are at a later stage. So we can confidently freeze eggs for women in these situations. And, it's the thaw rates are very good. And so, we do see a lot of women of reproductive age, and I think it's wonderful to be able to do these things now. So nobody needs a sperm donor is the point if they don't have a partner.
Right. And the issue is also that not everybody may be a candidate, and there's a reality to that, even without a breast cancer diagnosis. So I think being with a reputable resource and physicians who are well-versed and really know their craft, know their science, can really help handhold a patient to an appropriate place, whether it's a future pregnancy, optimal egg harvesting, or the reality of sometimes maybe, you know, it wouldn't have happened even if you didn't get breast cancer, if we weren't dealing with fertility. So I think the conversation is so important. I really try to encourage all of our young patients, and we try to tell our surgeons, even before the patients get to us, let's get this all done at the same time. You know, let's not waste time, because we may not have the luxury of 4 weeks or 6 weeks or 8 weeks before we want to start treatment. You know, one of the topics that comes up is when we do administer chemotherapy, and even some of the milder chemotherapies, even the non-hair losing, non-cardiac toxic chemotherapies, we tend to age those follicles. We tend to age those eggs. So if somebody starts off, you know, at the age of 34 and is hopeful about a future pregnancy, you know, post chemotherapy, a year down the line or a year and a half down the line, those eggs may be those of an early 40. So again, even if someone hasn't thought about it, I do encourage patients to see someone like you, Erica, and your colleagues. So important. Colleen, you hear this all the time. I know that patients talk to you, and it's sometimes very sad, but sometimes very rewarding. We have lots of babies coming into our waiting room.
And it's hard to predict sometimes. You know, I think there's a role for the conversation before and also afterwards, because not everyone's going to go through menopause, but some of these agents are hard, especially in the women who are in their late 30s, early 40s. And so, you know, just having that conversation, okay, what options exist now? What options exist 2 years into remission? You know, how can we tell if you're in menopause or not? Because it's you know, we do the care throughout. It's not just at the beginning. It's the ovaries are endocrine organs, and they keep the bones happy, and they help protect the heart. And so thinking about long-term health, yeah, I see this. That's why we're all together tonight, is because, you know, we really help through the whole spectrum too. So, and, you know, I have to say this, I tell my patients all the time, there are many pathways to parenthood. And sometimes it's the strong plan A, which is, you know, a person's own genetic DNA. There are also other pathways, and, you know, people who want to become parents will become parents. And I think it's important, because there's this fear, you know, I'm never going to become a mom, and it may happen the plan A way, it may not happen in that exact way, but we help people become parents if that's what they want.
And oftentimes the patient will say, look, I just found out I have breast cancer. I have so many things that I'm terrified about. I can't have this conversation now.
Yeah, that's right.
And I think it is important we as providers have the tools available to patients to speak to a social worker, to put some of the information in context so they can file it away at an appropriate time, where maybe once a plan is there for their treatment, they're less frightened, they are less worried. I will say to the audience that for all the literature that's out there right now, and this is a topic that Colleen and I just tennis ball back and forth all the time, for all the literature that's out there, and again, there's a bias, because most women who become pregnant after breast cancer are usually those with small breast cancers, you know, favorable outcomes, younger patients. But there's nothing that says a pregnancy will worsen your prognosis. It may not improve your prognosis, but there's certainly nothing out there that would worsen it. And right now we have a really exciting trial that I think is going to be published over the next few years. Colleen, do you want to speak to that? How the trial was designed? Yeah.
Yes, so, you know, and Erica, you two probably can speak to this, but, you know, we're talking to a lot of our patients lately about interruption of therapy, you know, when to interrupt therapy, when to, you know, try to get pregnant, how many years into therapy do we decide to hold treatment? And, you know, there's a ton of questions lately from patients like, I want to have a baby, when can I? So, you know, right now there's a study that Maria was speaking to, and we have had some patients that have expressed an interest. And I'm not sure, Maria, did you hear still accruing?
So the PROMISE trial is a trial that was put forward. The principal investigator is Ann Partridge from the Brigham in Boston. It is a trial that looks at women with stage 1 to stage 3 breast cancer. These women have to have been on endocrine therapy, so ER positive disease, for at least 30 months. Somewhere between 25 and 30 months. And then they're allowed to come off for a total of 2 years and then resume. Patients cannot come onto the trial before they start endocrine therapy. They have to get some therapy in because we're always worried about a breast cancer recurrence, and that's still our first mission. But it has accrued now. They're expecting 600 patients worldwide. They have somewhere about 550 patients, so the trial is getting ready to close. And obviously, it's going to be looking at safety. And is it safe to interrupt endocrine therapy in order to become pregnant and then resume it? Will it change disease-free survival and overall survival outcomes? You know, our treatments are so they are so empowering and so successful today that it will be years before that we have that information. But at least now we have a formal study with a fairly large number of patients, and it will speak to safety and hopefully pick up any signals. Anything that anybody wants to ask on this topic? I know most of the questions that are coming in are going to absolutely wrap around Azeez, so get ready. They're beginning to come in about everything that has to do with bone metabolism. Erica, I'm going to jump from you actually to Heather, because it's not just pregnancy and having babies. You know, our patients are young, we're treating them more effectively, but our treatments can have cardiac side effects. We've known that for the past almost 30, 35 years since we started using anthracyclines. Now we have life-saving anti-HER2/neu antibodies for a very aggressive subtype of breast cancer that had a huge mortality that now has become such a successful treatment for these patients. And the issue is, who are those patients who are at risk? What is cardio-oncology? When does a patient get their echocardiogram checked? And when do we send them to you? I think I'm overburdening your practice and your colleagues because I want my patients seen, but can you speak to that? It's so, so important.
Absolutely. Just as a brief look over of what cardio-oncology is, I'm a cardiologist by training. I do have a special interest in oncology, drugs and regimens and how they can affect the heart, both during treatment and a lot of the fact is many years after the treatment. This includes radiation, chemotherapies, and immune therapies, which are new drugs are coming out honestly every few months. What I'd like to talk to people about is that there are certain people who could be more at risk of those toxicities, and they're very rare, what Dr. Theodoulou and I see on the cardiac side, but with healthy screening, both before you start and during your treatment, we can intervene if necessary, and sometimes start cardioprotective drugs, which can help to preserve the heart pumping function and allow that person to stay on this life-saving cancer therapy. So I see, much like Dr. Bove, many different age ranges of patients, both women in their 20s, all the way up to, we have a special patient who's 92, 95 years old that we see who's doing well on her Herceptin and Perjeta therapy. What I would normally start with is we would do evaluation to see what your risk factors for potential toxicity are. If you have underlying issues like hypertension, diabetes, high cholesterol, maybe a family history of cardiomyopathy or congestive heart failure, we may intensify therapy or start something sooner on you. Otherwise, depending on your therapeutic regimen, we may use echoes, which is an ultrasound of the heart, to screen for any changes in your heart function every 3 to 6 months, sometimes a year, depending on the treatment regimen that's brought forth by the oncologist.
You know, I always tell patients that keep your healthy parts healthy. and you are who you are when you walk into our door. And obviously there are women and some men who are at more increased risk, those patients who are hypertensive for many years. We've looked at some of the studies with anti-HER2 drugs, and some of the risk factors were over the age of 55, an ejection fraction less than 55, being hypertensive on medications. But when we look at those numbers, they're still very, very small. But for that small percentage, whether it's 1.7% that might be symptomatic, or maybe larger that is silent right now, we're unaware of it. And remember, our patients are surviving a lot of these diagnoses that were not treatable just 10 years ago. So women are living longer, men are living longer after being exposed to these medications. And we don't know what's going to happen 30 years down the line, 25 years down the line. So certainly understanding risk factors of patients who come in, their BMI, whether they're obese, all of the other issues that might put pressure on their renal function, and other issues become all very, very important. I certainly refer my young patients because they do have another 60 years ahead of them. I refer my patients who have comorbidities, and especially hypertension. And then we have to be very, very careful. It's rare that I have to take someone off therapy, but every couple of years, there's a patient unexpected that has some cardiac dysfunction. And, we don't want to save patients from cancer and make them a cardiac cripple. So I think healthy lifestyle. And when they get to see someone like Heather, and one of her colleagues, and this goes across the board, wherever you live, whoever you're seeing, really taking aim and taking care at keeping those healthy parts healthy. They'll be your best friend down the line, not your medical oncologist. It's those healthy organs. Heather, question, everybody is looking at cardiac function in all sorts of different ways. We have some clinical trials now that are looking at protective medications. We talk about, in some places, doing a strain versus not. It's not across the board. We haven't really unified across the country in our oncologic communities how we should be following patients. What's the very minimum that we should be doing in someone who is exposed to a potentially cardiac toxic drug?
My first goal would be to get an echocardiogram, where MUGAs used to be used a lot in the past, but I feel that they give the patient some excess radiation risk. With an echocardiogram, it's not invasive, it's external, relatively quick and easy to do. I have been trying to do strain imaging on most of my patients, which is, if a patient comes in, I explain to them, it's looking at not only the squeeze that we look of the heart this way, but longitudinal strain looks at how the heart shortens like an accordion. And what we found is that that longitudinal strain will change before the ejection fraction or the radial ejection fraction changes in a patient, which could lead to clinical troubles down the road. You could also do a cardiac MRI. However, feasibility and cost of that machine is less likely to be implemented. So I think echocardiogram, presumably also screening. In my office, I check for high cholesterol levels, either during or post treatment. We obviously look at hypertension, and I'll assess some of these medications can affect the rhythm of the heart, or it changes with your EKG. So I normally get an EKG as well.
So questions I was receiving over the past week from patients, and I promised them that I would throw it out to you, because they say, well, Dr. T, you're the expert. And I say, well, I read the articles. They say, we don't want to hear from you. We want to hear from the expert. And, does an aspirin low dose once a day help? I know the data. I'd like for you, if you could just throw out a blurb about that. What about statins, cholesterol lowering medications? Could you speak to that?
Let's go with aspirin first. So I think prior to this, everybody just said, take a baby aspirin. We found that that is not the case. It's not beneficial for just a blanket statement on everyone above a certain age. That is where a careful discussion with yourself and your medical provider needs to come into place. We look at your propensity to get cardiovascular disease 5 to 10 years down the road. And through a calculation that we do in the office, or assessing the patient, we can see if that may be beneficial for you. Sometimes we can use something called a calcium score to also implement a statin therapy or aspirin therapy. Then we get into statins. Statins have some anti-inflammatory benefits, and there have been some publications that show with cancer therapy, there may be improvements on statin therapy due to that anti-inflammatory benefit. So if you have borderline cholesterol and you have risk factors that would be worried for you from in the future, it may be beneficial to have that discussion about implementing that preventative cardiovascular medication during your treatment or prior to it.
I see Dr. Farooki nodding, as you're speaking. And Azeez, I'm going to ask you right now, because you are an endocrinologist, although you do basically teach everyone about bone metabolism, how providers should be caring for patients and how patients should be caring for themselves. What is your take on statins in the environment that we're talking about?
That's a good question. I mean, I do like to try to use them if I feel like the patient has sufficient risk. And, as was just mentioned, there is this really intriguing data that is not randomized data, which we would use to make a, definitive recommendation to say, yeah, that there's good evidence that this is going to help your cancer outcome. There's not that kind of data, but there's a lot of associations out there and big epidemiologic studies that it could help the breast cancer outcome. And so, I mean, if that ever could be done, then there would be a trial where they would give the statin or a placebo and see. But I think statins, I mean, frankly, I mean, I think they're very safe drugs and, almost should be in the water because they really, I mean, people die of cardiac events, and I think they're really good at preventing it. And we know the lower you drive the bad cholesterol, the lower the event rate is pretty much. So,
and it goes back to keeping your healthy parts healthy, because we don't know what our individual immune systems are like or what the stromal environment is that our immune systems function in. Could be very different for Arsyl, very different for Colleen, for Erica, Heather, myself, Azeez, and we're clearly not the same, and we all have different roadmaps that we take. But I have to tell you that statins and vitamin D and really paying attention to glucose metabolism, I think is just such a simple way to try to perhaps better outcomes, although we're a little further away from having the kind of information that we need to cement it. Glucose metabolism, we hear about it all the time. Patients want me to prescribe glucose lowering agents because of some trials that were performed up in Detroit several years ago and some trials that are ongoing. Some of them have come back negative. Can you talk to that at all? And then I think we're going to spend a lot of time on bones.
Yeah, my favorite. The glucose thing is very interesting because, again, there are these associations with high insulin levels, right, by this investigator, Dr. Pamela Goodwin in Canada, right, Maria?
Yeah.
And recurrence risk. And then I believe that the trial where they gave metformin to women who generally were overweight or obese, had high insulin levels, was negative as far as I understand it.
It was negative. And
Yeah.
that kind of made me sad. I was kind of hoping it would come back as a positive trial because it's really a fairly benign drug for most patients, obviously not for everyone. There always could be an allergic reaction. But, from Canada, we also got the vitamin D data initially before we really started to look at it in relation to breast cancer. Please speak to us about that.
I mean, the interesting thing though about the glucose thing is 2 points. One is there's really a lot of interest in if you have a PI3 kinase mutation and you have metastatic breast cancer from the folks at Cornell, Dr. Cantley's lab, and actually a former fellow of ours, Dr. Goncalves, they want to try to lower insulin levels through diet, which you can do with a low carb diet or a ketogenic diet, let's say. And they're studying that in a trial, patients who are on a PI3 kinase inhibitor with metastatic disease. So that's one whole niche,
And that's an
separate.
important niche because so often our PI3 kinase inhibitors do cause a diabetic phenomena. And
Yeah.
so, it's really sprinkling salt on a wound. Yet, if we look at our ER positive patients and we look at cell lines, close to 50% of those cell lines are, PIK3CA positive. So it's not, a small number.
That's interesting. Yeah, and I mean, for everybody out there that's saying, well, why would you want to lower insulin? The reason is that the pathway that insulin activates, in the cell is the same pathway that's blocked by these drugs, the PI3 kinase inhibitors. So if you're drinking sodas and your insulin in your body's skyrocketing up, or even some Boost and Ensure have a lot of sugar, right? Then that's actually fueling that pathway. And it's not really, the evidence is only in mice that it makes, it might help the outcome if you change, if you modify the diet and so forth. It is enough to really, warrant the trials that are ongoing, really.
We've become almost exhausted discussing vitamin D with our patients, and certainly
Yeah.
it has a huge impact when it comes to bone metabolism. Although the study we alluded to that came from Canada seemed to say that if we had sufficient levels, good levels of vitamin D, that our breast cancer recurrence rate may be lower. And, that was an observational study. It was not a randomized trial. At least I don't know if any randomized trial has come to fruition, but it kind of piqued everybody's interest. Was it because there's less sun up in Canada? Are they getting less, vitamin D from sun rays, and there was all sorts of speculation. But I have to say that although I am really strict about vitamin D in all of my patients across the board, and obviously with bones being the major recipient of that benefit, it always is in the back of my mind that it may help them from a breast cancer perspective. We just don't know as yet.
Yeah, I think that's true. A lot of the studies with the extra bone benefits of vitamin D since the initial enthusiasm, maybe like 10 years ago, have unfortunately been negative because, could it help cardiovascular disease? Could it help autoimmune disease, this and that and the other thing? And I mean, or infections and, falls. And a lot of this has just been not really panned out.
Yeah.
Could it prevent cancer, new cancers? There was a big study in the New England Journal, but the problem is that they gave the population they studied, everybody had decent vitamin D levels. So then, you wonder what's the utility, what's the answer? But if they look at the patients who had low vitamin D levels to begin with and who were lean as opposed to obese, there was a reduction in cancers in that study.
Interesting.
Yeah.
Tell us about our bones. I remember my wonderful endocrinologist, who will name unnamed, told me 6 years ago that if I wasn't careful, one day I would get up from an examining room table and leave powder back on the table because I was misbehaving as far as my bone health. And talk to us about when we should start looking at our bones, regardless of a breast cancer diagnosis. Let's talk about what women should know about their bone health, when they should start being evaluated, what the guidelines should be and are. And then I'd love to be able to talk about some of the things that we do to our patients: early castration, early menopause, some of the medications we give like letrozole or anastrozole or exemestane that could potentially decrease bone mineral density. Loaded question.
Yeah, it's a big topic. I mean, honestly, to start with, I don't really like the scare tactics. Me, other docs do that. But, I think as long as you're taking it seriously.
Don't say anything. He's my endocrinologist. Okay.
As long as you're taking it seriously, we have a lot of good medicines out there, and you can be treated effectively, and you're going to be okay in the end. But the question you're asking, when do you start checking on that stuff? I mean, it's a debatable question, but in the general population, I mean, personally, somebody has a strong family history of osteoporosis, one of their parents broke their hip, and maybe they phenotypically resemble them or whatever, they look, they take after them. Then, I mean, at menopause, as a woman's going through menopause, they can stand to lose a lot of bone in 5 to 8 years. So it might make sense to check a bone density test in that kind of patient who has risk factors, as we say. The standard guidance is at 65, every woman, and at 70, every guy can get a bone density test paid for, no problem. And before that, you're going to need to justify it a little more, and certainly our breast cancer patients that are on premature menopause and are on medicines like aromatase inhibitors can qualify for early testing.
And patients who have osteoporosis or get a baseline bone density, and we see that they have osteoporosis and they were unaware of it, is it just a matter of treating them in order to strengthen their bones, or should we be thinking about other metabolic issues that may be contributing to it?
Yeah, that's a really good point. Yeah, we always, as endocrinologists, we look for other metabolic issues, like do they have an overactive parathyroid? Are they on too much thyroid hormone? I even had a patient, this was crazy, she had excess fluoride level in her blood, very high fluoride level, and that was a result of abusing substance, but that's a whole nother can of worms. So yeah, I mean, the way you think about it though, you gain bone in the bank up until you're about 25, and then things are fairly steady up until menopause, and then there's a rapid phase of bone loss. And then everybody tends to lose a little bit with time, that the cells that put it back, take out, they remodel the bone, take it out and put it back. There's a little net loss over time. So, the thing that I want to emphasize though, that the 50-year-old patient with osteoporotic bone density, their risk of breaking bones is much less than the 75, 80-year-old patient with osteoporotic bone density. So for me, when I see those type of breast cancer patients, I'm explaining to them that, look, I'm not worried about you breaking bones left and right necessarily now, although, with the aromatase inhibitors, that people certainly can break bones, but we're trying to preserve your bone health for when you get older, and your risk will go up higher.
Patients come back and they say, Dr. T, I don't want to start this medication. I know you're telling me that it's a standard of care. It can increase my disease-free survival, but I've read that it can cause kidney issues. I've read that I'm going to break my bones. I've read
jawbone problem,
meltdown of the jawbone, osteonecrosis. And I know that you've written quite a bit. And also, the treatments for bone mineral density loss. I refer my patients to endocrine. They come back and they say, well, I don't want to take this bone modulating agent. I heard that my femur can fracture, down the line. Could we put into perspective what the guidelines are? Because the percentages for these side effects are low. And
yeah.
I think sometimes I tell my patients, go and read the PI for Tylenol. You'll never take another Tylenol again. So if we can speak to, the jaw, and if we can read the kidneys, that would be great. These are questions that we get all the time.
Yeah, sure. No, I appreciate that. And, it is scary to read about some of these things. I mean, I would say that starting with the jaw, that issue is really something that we think about in the setting of patients who are used to be getting monthly dosing, as of zoledronic acid, the IV medication, or monthly dosing of denosumab, Xgeva, who have metastatic cancer in the bone. So they were getting very high intensity dosing, and they were a little sicker, right? Because they, had metastatic disease, getting chemo, what have you. So in that setting, 1 in 200 people per, at most per year, let's say, maybe even less than that, would be at risk for getting this jawbone problem, the area of dead bone in the jaw. And most of the cases follow an extraction. But if we look to the osteoporosis world, it's completely different. And I mean, I always cite that there was a study of 8,000 women, half got placebo, half got this IV medication reclassed. They got it once a year for 3 years. And there was one case of the jawbone problem in the placebo and one case in the drug group. And another study every year and a half.
Out of 8,000 patients.
8,000, and it was a wash. It was 1 and 1, and both of those patients had sort of other conditions, diabetes and what have you, to predispose you to not only diabetes that was not well controlled, So, yeah, so there was really the same as placebo in that big study. And then a second study looked at every 18-month dosing, and they didn't find any cases. And then the Austrian study with Prolia, which is a shot every 6 months, bone protection shot, they found no cases that were found to be osteonecrosis of the jaw in their 3-year study as well.
And the importance, again, is that, education, making sure that patients are up to date with whatever orthodontic work or tooth work or dental work they need to have before we initiate these medications. But, I'm glad that you spoke to this. Can you tell us a little bit about the difference between some of the oral agents, drugs like Prolia, how they work, drugs like Reclass? What are some of the newer agents that may be there? Who would benefit from it? I told you I would corner you. Okay.
Of course, that's what I'm here for. I mean, the good things about the IV drug, the zoledronic acid, or otherwise known as Zometa or Reclast, and the shot, the Prolia, are that there is some evidence of adjuvant activity, meaning that it lowers the risk of cancer recurrence. And I think the evidence is stronger because there are many more trials looking at it with the IV drug, and those trials were pooled together. And so not only do you get two benefits, it reduces your risk of getting broken bones, protects your bone density, and there's probably this, anti-cancer effect that makes the bone inhospitable for the breast cancer cells to recur in of that drug. And I think we need more studies with Prolia, but the Austrian study that was done was quite impressive in the specific population that they did it in. Second study did not show benefit in different population. So the oral drugs, the oral bisphosphonates, there's just not enough data to say whether they have this adjuvant effect. And you can't take them if you have esophagus problems. If esophagus doesn't empty. If you have reflux, that's not a big deal, honestly, to me. The pills, they have to be taken just so, or they don't get absorbed. So they're a little more labor intensive. I mean, I'm lazy. I would say, give me the IV, because I don't want to be bothered to do it all the time.
Can you speak to the issue? We have patients with metastatic disease. They do see more bone modulating agents than someone in the adjuvant setting or in the real world healthy setting. Patients who were getting IV drugs fairly frequently, we had data published at Memorial Sloan-Kettering Cancer Center about long bone fractures. And I know you were involved in some of that literature.
Yeah.
Can you speak to that?
Yeah, absolutely. So, I think the trend among physicians in general used to be that just keep giving it and giving it. But we know that could be overdoing it in some people if you're going to give them 4 years of monthly dosing of, some of these very potent bone drugs. So we looked at a study where we looked back at charts, and more than 24 doses of the IV drugs were given in the population we looked at. And we found like 4 out of 300 and something patients had developed this femur, the thigh bone stress fracture. And that they had like 40 doses, so it was a tremendous exposure in a short amount of time. So way more than most osteoporotic patients get. But still, if somebody's been even on Fosamax, alendronate for more than 5 years, we do, just out of being careful, we know that there is some risk. 5 to 10 years, the risk is probably 1 in 5,000 of getting a stress reaction in the thigh bone. And it's more common in Asian American women. So, we always, as doctors, we always think about these rare things and take it seriously. But the risk benefit, to put it in perspective, I mean, I have a slide where it breaks down risks. And I mean, your risk of getting hit by lightning or getting in a fatal car accident is more than getting osteonecrosis of the jaw or this femur fracture, from osteoporosis drugs. So it's not something to lie awake at night about.
I agree. I agree. Can you tell the audience how some of these drugs actually work? I spent a lot of time discussing the mechanism of action. Can you give it to us in lay terms and how these drugs actually work?
Yep. Yeah. The way I think about it, your bones are constantly repairing themselves. And you have these cells that take out the old bone, and you have the cells that put back down the new bone. So you can think of it as like the demolition crew and the repair crew. And after menopause, especially, the demolition crew is working overtime and the repair crew cannot fill in those pits in the bone. So these medicines, they tell the demolition crew, hey guys, just calm down a little bit. And they let the repair crew fill in the holes in the bone and fill up the pits that are made. So what happens is that
I love what you just said. I just love that. I'm going to use that from now on.
Good. I'm glad. Yeah, I think it works for, simple, and I like simple too. So, I mean, so you're getting more mineral in the bone, and the bone density goes up, and the fracture risk goes down. Now you're not making new connections in the bone. The bone is like a web, and it has these horizontal connections in it. So there's only some what's called anabolic drugs for osteoporosis that do that, but those are not unstudied in the breast cancer context. So we don't usually give those. The thing that patients often go on the internet, and I don't blame them one bit, and I mean they look it up and say, look, doc, this drug is not building new bone, it's building brittle bone, and you see this is not good bone and so forth. But I mean, in multiple 3 or more year studies, when you compare these anti-resorptive drugs that lower the demolition crew, you reduce fractures. So that's the bottom line. I mean, we care about not theoretical things about brittle bone and all that. We care about the patient getting less fractures.
And I think the one thing that we have to remember is that bone is a live tissue.
Mhm.
It's a living tissue. It's not something that's just inanimate. We're getting to the point where I think we should look at some of the questions. Arsyl, what do you have up there?
Yes, Dr. Farooki, can you comment on Zometa in patients, the use of Zometa or zoledronic acid in the patients with osteopenia and postmenopausal and on anastrozole?
Yeah, I mean, there was a study in the New England Journal a few years back that they gave actually Zometa every 18 months to women with osteopenia who are around 70. And they showed a reduction in fractures. So I thought that was useful to know that only every year and a half. But in women on aromatase inhibitors, we know that their fracture risk is higher, definitely. And normally with osteopenia, we would plug in the numbers into a calculator called FRAX that's online, FRAX. But with the aromatase inhibitor, the risk is going to be higher than is calculated. So I think that's a very effective drug. Yeah, I use it all the time in women on aromatase, with maybe once a year, debatably every 6 months, if in that population.
Thank you, Dr. Farooki. I'll jump to the heart. Dr. Stahura, any comments about one, the effect of Herceptin Perjeta in the normal aging process of the heart, as well as any negative effect on the heart with anastrozole or the other AIs or tamoxifen?
Sure. Let's start with the Herceptin Perjeta first. The biggest concern that we have of the heart, as the heart ages, there can be some changes that we see with it. But again, that's why we take an echo, the ultrasound of the heart pre-treatment to compare. So we know if it's a precipitous, if it happens or if it happens quickly, could be more likely due to the medications. It doesn't typically affect heart valves as much. It more affects the heart function or the ejection fraction squeeze of the heart. Other things, if you have radiation, it could affect heart valves or the pericardium, the sac that sits around the heart. So again, it's every case is different. We try to look at what you're exposed to. On the question of tamoxifen can, very rare for it to affect the heart, like make it not squeeze well. It more can affect things like high blood pressure. Sometimes it can affect your lipids and cholesterol. and it can cause sometimes clots to form, most notably in the lower extremities. The same goes for, we were saying anastrozole, any of the hormone medications. They can affect blood pressure, cholesterol, and rarely can affect heart function. We screen for all of those.
And just for transparency, it's when we're deciding to use some of the endocrine agents long-term in those patients who have a higher risk of recurrence. Again, emulating what Dr. Farooki said, the risk-benefit ratio in those patients who are at higher risk for having a recurrence, which would be relatively incurable, then, we do pay attention, closer attention, once a patient is on these drugs for 7 years or 8 years or 10 years. But again, having a relationship with their primary care physician and their cardiologist to make sure that their blood pressure is well controlled, that their statins are well controlled. Yes, they may need medications, but no one is going to recommend long-term use on there unless there's a reason for it. And again, then we have to weigh everything. As far as clots are concerned with tamoxifen, it's a real issue. It occurs in about 3 to 4% of patients. It's not an extraordinarily high risk. We always ask patients if they have a history of coagulopathy or if they had any issues with clots during a pregnancy, if they're sedentary. One of the issues with tamoxifen that I pay a lot of attention to is mood alteration, and which can be life altering for some patients, especially if they have a prior history of depression or any kind of a psychological issue. Arsyl, I'm going to turn it back to you.
Thanks, Maria. This is maybe Colleen. You can help answer this one. One of the some patients, not all, some patients have fairly debilitating joint pains on these aromatase inhibitors, and really don't want to take Tylenol daily. Any suggestions rather than stopping the medication?
Yeah, no, it's interesting. And Dr. Farouk may or may not support this anecdotal evidence, but I tell patients a story. So I have a Labrador Retriever, and she has a lot of joint pain. So I'll often tell patients, I often will give my dog glucosamine chondroitin for her joints, and it makes a tremendous difference in her joint discomfort. So anecdotally, I've been telling patients, maybe just try some glucosamine. Let's see if it makes a big difference. And the patients come in and they're like, "You're wonderful. Like, this medication is making me feel so much better." Now, granted, there's no real scientific data supporting this. However, it seems to be working for some patients. Some of my patients will take vitamin D. They say that helps some of their joint discomfort, and move. The more they move, the better. Sitting on the couch, all day long, having your joints get stiff. So I always say, the more you move, the more active you are, the better you're going to feel.
No one knows the mechanism of action of these arthralgias and myalgias that are caused by aromatase inhibitors. It occurs in about 20% of patients in different variations. Being sedentary is the worst thing, and it will exacerbate it. I mean, if you're going to be prone to it, that's going to make it happen. Certainly obesity, and we talk to our patients about healthy lifestyle, getting the weight off of their joints, but really moving, doing, and exercising, using their fingers. I had one patient who was very high risk, who was really married to her aromatase inhibitor, even more so than her husband, did not want to come off it, but would tell me, "I wake up in the morning and my fingers are like this, and I have to uncurl them in order to get my day going." And then she's fine for the rest of the day. And again, we don't know what causes it. And I always think, we have to look at what was going on before we started these medications. There have been rare instances where I picked up rheumatoid arthritis, not because the drug caused it, but because it unmasked it. Because the patient was having an exacerbation of their joint problems, that we started doing a workup, and we found out that they had an autoimmune or rheumatoid arthritis issue. Sometimes we'll see that after chemotherapy. Once they stop the pre-medications with steroids, all of a sudden they have this syndrome that develops, not because of the drugs, but because it was lying there in wait, and we just unearthed it. So, exercise, walking. I tell patients, walk uninterrupted 30 minutes at minimum 3 times a week. Do not stop to admire a tree. Get 1-pound weights, put them on your ankles while you're walking. Put them on your wrists and walk, and really kind of exert yourself, especially women who don't have the opportunity to go to the gym or work out. Not everybody has that luxury. Colleen, you can take it back.
No, I agree. I think the more we move, the better. And, occasionally patients will want to blame a lot of the side effects on the drugs and, want to stop their therapy to see if their symptoms go away. And they'll actually stop their therapy and the symptoms are the same. So they need to get up, they need to move, they need to do, I think for all parts, for our heart, for our bones, for our joints, the more we move, the better.
And no better proof of pudding than Colleen, my nurse practitioner, who is an Ironman athlete multiple times. So take it from her. Arsyl, other questions? We're getting very
Yes.
close to the end. We have 1 minute left.
Yes, Maria, this might be actually for you. Lady said that she was on anastrozole for 1.5 years, switched to exemestane for another 1.5 because of debilitating joint pain, and ultimately had to stop after 3 years of intake because she also has severe degenerative joint disease. Now she is not on any hormonal therapy, and she is wondering about her risk of recurrence and or potentially, I'm going to add on what are her other options, if ever?
So look, when we talk about risk of recurrence, we are empirically citing a number. When I have a patient, and I'm just going to use this as an example, you have a 50% risk of recurrence. That means you have a 50% of never having a recurrence. You have a 10% risk of developing a recurrence. You have a 90% risk of never developing a recurrence. And we have to keep that in the forefront of our minds. Patients who are on endocrine therapy are on endocrine therapy because they have estrogen positive breast cancer. And we know that using these drugs for 5 years, it's better than 3 years, better than 2 years, better than 1 year. But if we can get 3 years in, and there are some investigators in Europe that are looking at 3 years, then yay, yay. Drugs are made with different expedients in order to get their patents, in order to have the drug delivered throughout the system. And sometimes patients will tolerate one drug better than another, even within the same class, because of the different makeup of that drug. So we don't know what the science is. We try to do the best, and there's no question that quality of life is hugely important. I don't want somebody to sit in a chair unable to move for the years that she's on her endocrine therapy. But then, we have to look at that patient, and there are probably 3 to 4 patients a year. Now, I see hundreds and hundreds and hundreds of patients. I have a huge denominator, thousands of patients when I look at my total practice. I know it wears Colleen down, but there are occasional patients that we have to take off of drug therapy because they are intolerant. Heather, you can speak to that. That there are patients who have joint pains from statins. And sometimes, I'll get blamed for the joint pains when they've just started a statin. And I'm sure you confront that same issue. I think we have 2 seconds, and I'm going to say right now, thank you. This hour went by so quickly. Azeez, you know that I was going to abuse you. Erica, I hope you're going to come back. And Heather, I want to thank you for always being there pre-pandemic at all of our live survivorship programs, and all the incredible donation of your time you've given to so many patients in so many forums. I'm excited that we have this program going forward. Just to say that we're able to do this program about 7-8 times a year on different topics with different panelists because of an incredible donation and grant that we got from one of my prior patients from Memorial Sloan-Kettering Cancer Center. Azeez, I don't know how to thank you enough. I think we're going to say good night. Thank you, everyone. Until next month. Next month, we're going to talk about, we've talked about below the waist. We've talked about Wellcare. We're going to talk about the mind and the words breast cancer. So good night, everyone.